wonderful person with a 30-year career in cybersecurity and information technology. In launching HSR.health, Ajay leverages the best of tech to transform American healthcare into a system that innovates healthcare delivery, achieving improved quality, lower costs, and health equity. The company has discovered a means of predicting future health risks based on social and environmental determinants of health and works with public health, government at all levels, and a business to assess the impact of those risks to their operations, assets, and the populations they serve. Let's see, when Ajay isn't using the HSR.health geospatial platform to map disease rates against social factors to identify solutions to population health challenges such as the opioid epidemic or maternal mortality, you can find him at sporting events or behind the mic, bursting eardrums while belting out his favorite pop tunes. He is a healthcare innovator, patented inventor, invited speaker, published mentor, multi-award winner, and he's a friend of the Healthcare Council and ShareSource. He's spoken to multiple divisional groups within the Healthcare Council, and he has served as a faithful and valued mentor in the Healthcare Council mentorship program. In fact, this fall is his 3rd year, and we appreciate that so much. So please welcome your Solutions Corner speaker for today, Ajay K. Gupta.
Hello, everybody. Thank you. Thank you, Donna, for that wonderful introduction. I mean, I'd like to meet that person too. I don't know if that's necessarily me, but
well, he's a great guy.
And I want to thank everyone from the Healthcare Council for this opportunity and everyone for attending as well. We are Healthcare Council and ShareSource members and proud to be an endorsed partner with the council. So I'm going to talk about some of the things that we've done, but this is your time. So anyone would like to ask a question related to what we're doing or just in general about the use of artificial intelligence in healthcare today and into the future, feel free to stop me at any time. We have been around for quite some time, so we could certainly talk for the whole hour, but I hope that we don't have to do that. We will ask me questions, stop and interrupt me and ask me questions. Let me share my screen. There are a few things that I want to say with respect to just background of the company, and then I will have Paul Churchyard is our CTO. I'll introduce him in a second. We'll have him do a few demos periodically through the time. Let me run this in slideshow. Figure out how to get to it. Okay. So I'm in slideshow. Carrie, Donna, I can't really see any questions, so please help monitor the chat. But okay, so this is us, right? I spend just a second here because obviously when we are doing business, and especially in the business of healthcare, we know that trust and just knowing who you're working with is important, which is why I put in my bio that I am honestly a lover of karaoke, right? That's kind of important in working with me. I also like to run and serve on a number of positions outside of HSR.health, the Commission for Nurse Reimbursement, as well as I'm board chair for Holy Cross. I've been in this position for 9 years. And last year we went through a merger, and now our system has hospitals across Pennsylvania, Maryland, and Delaware. My partner, who some of you may know because he's also in healthcare in the state of Maryland, is a dual board certified anesthesiologist and pain management doc, Ram Paravemba. He's had a hand in Maryland's waiver system and actually led his practice through a PE acquisition to create the largest anesthesia practice in the country. We're both named inventors in all of our patent filings. Ram is a better runner than I am. He's actually rated globally for his age group. He's both, in addition, a guitarist and an excellent golfer. So yes, we have performed together. Our CTO, Paul, get a chance to interact with a little bit in a second, is an expert at geospatial technologies and data science in all kinds of ways. So any questions about particular algorithms, feel free to talk to him. And he's also well known in the global disaster and risk emergency management community. having done a lot of work in there. Our company has done a lot of work there with respect to the health risks in disaster situations. Also, feel free to congratulate him or send him, commiserate with him because he's a newlywed and he is a DJ. I won't spend a lot of time here talking about hospitals being under pressure because, of course, I'm sure this audience is very well aware of these and other strains on healthcare. I just mentioned them to put our services in context. We know there is rising clinical complexity. We know we are facing workforce constraints in a number of ways, and we know we get to experience reduced federal spending in the near future. So what does that mean for healthcare? Healthcare does need actionable insights, but often artificial intelligence offers blind spots where we find that a vast majority of internal data is never really analyzed, or that it's a black box scenario where it gives you a result that's potentially actionable, but without knowing how it arrived at those results. And when you pair the lack of explainability with a hallucination rate that remains high, I did see at latest trends that some of the newer models are hallucinating at a 25% rate. That's still too much. And customized solutions, and by that I mean solutions designed sort of from the ground up, take both too much time and money, and we just don't have the capacity for either. So in that context, what does good AI look like? Well, we know it has to be explainable. We want to understand how or why the AI is saying what it's saying. So in the context of health, if it is saying that a patient is high risk of something, what are the factors that created that risk? If it's saying a community is at risk of certain level of disease prevalence, we want to know the underlying factors so that we can treat or help avoid those underlying factors. It also has to be actionable. It has to be fastly actionable, meaning that rather than a complex dashboard or platform to get at the data, some kind of generative or conversational prompt-based interface is better. And then that needs to be integrated into workflows. This is not to suggest that you can't use the deployment of an artificial intelligence solution to improve your workflow if that is something that you want to do to achieve greater efficiency. But it needs to be your choice. You don't want to have the AI mandate a new workflow because we know that on the floor, that's just how it doesn't really work. And then there's this classic case of the balance between accuracy, cost, and speed. Obviously, we want accuracy. But if it's coming at a high cost, then given our current budgets, it's a no-go. And if it's going to take too long, we will, if you will, we've already had to treat the patient, it's not effective. So we need a way that balances accuracy, cost, and speed. And our approach is, as we'll see, we use an orchestrator to allow us to pick a model that meets the cost, speed, accuracy requirements on a per use case basis. So for those areas where accuracy is paramount, we do what we can to have accurate results, to pick the models that are most accurate. For those areas that accuracy versus speed may be a different scenario, maybe non-clinical areas that are more relevant about social factors in the community, for instance, our orchestrator can pick a different model. Essentially, we can play the role of a conductor that produces a harmony by balancing the percussion, strings, wood, and instruments of an orchestra. So then, where do we start? We followed this same process. It's very simple, essentially two-question process when we started building our solutions. First, what is it that we really need, right? To do our job better, to do our job faster, to do our job at lower financial, cost structure. What is it actually that we need that we don't have today that will make a marked difference? And is that a point solution that we want to fix? For instance, in our entire operations, is there one problem point that if we just made that problem go away, everything else would be good? Or do we really have a need that is broad-based and will address lots of things across an organization? So we grappled with this, which might seem like a simple set of questions. We grappled with this for a while, and that what healthcare really needs is better insight into the social and environmental factors outside our clinical walls that are impacting the outcomes of our patients. So a patient is an individual who lives in the community. Something happens, they come into our space, and we can treat their clinical conditions and make them better. And they go back out into the space they came from where they got that injury or that illness. So if we don't know about that environment, the cure we give them, we know it's going to be limited utility overall. So we spent some time curating social and environmental data from numerous sources, non-clinical factors, and then are able to put them together. And we've put them together into an all-purpose tool that has many needs: risk stratification for things like readmissions or adverse outcomes, as well as what we'll talk about today, our community health needs assessment. So now I will pass to Paul to share our social determinants of health needs risk assessment. So what this is you see, when we do a CHNA, we want to know the social factors of our catchment area, of our primary and secondary service areas. And it does take time and some energy to capture the data from that area. We've spent that time and energy, and we can now do that for the entire country. If you zoom out a little bit, you'll see Alaska and Canada as well. I'm sorry, Alaska and Hawaii as well. And yes, we do have social factors data for Canada and for parts of other countries of the world too. But we're talking about America. We can show social risks for numerous individual social factors for the entire country at the state, county, zip code, and census tract levels. This here is a public dashboard, so we stop at the county level. But if you pick a state, Paul, could you pick Tennessee? And I like to look at Tennessee because my daughter lives there, so I just want to see how things are going in her place. And you can see immediately when this loads up that which counties and which areas are high risk for social factors. Let me stop there for a second. So there are many risk indices that say they address the impact of social factors, and the social vulnerability index, the area deprivation index, and there's so many more. They're all purposed for a particular thing, which is fine. But we find that when you do it in that regard, you miss what the overall strain from social and environmental factors on health outcomes are broadly across the population. So our social determinants of health risk index is just simply addressing how much strain on health outcomes are the people in this area exposed to. So that it's just a generic look at the true impact of the community we live in and the community we spend time in. We can look at this at the state level, county level, zip code level, and census tract level, and compare it to individual data points. Could be total population. It could be those without insurance. It could be a data point relative to your particular hospital. It could be something of particular interest to an individual hospital or health system, so that you can compare for your patient population how they are feeling and dealing with the community interests or the community strain, the community health needs that they're exposed to. And we feel this forms the core of a CHNA. It also forms the core of data that can be used by certificate of need information. Many states are certificate of need states where the health system or the organization has to prove the need for health services. Well, social data down to very granular levels goes a long way in assessing what level of need, what healthcare access need is available. And I'll pause here for a minute for any questions before we switch back to the slides. Thank you. So the community health needs assessment, as you know, as we all know, is an IRS requirement for nonprofit hospitals. It asks that hospitals identify the community health needs of their catchment area, their primary and secondary service area, as well as develop a plan for how they will address that need. So often we've seen that hospitals have challenges in capturing what the right data is. It's can be time consuming to actually reach out to the community. And so we have taken the lead and done a lot of that data collection work. We've done that work for catchment area and for the country so we can put it in great context. And we can produce that almost at a push of a button in terms of we can meet with a particular hospital and learn what data may be of interest to them. For instance, go to the next slide. Hospitals in areas that are prone to summer heat may want to know not just the community health needs of social factors, but also specific risk to exposure to extreme heat, which we did for Manhattan and New York City. We've also done in other areas around the country since then. This heat health risk index was produced and funded by DHS, National Geospatial Intelligence Agency, and NOAA, piloted in New York. Or hospitals may know that they want to understand food needs and food risks in their community, which we did in Florida in the upper right. They may want to have an interest in mapping social factors against their own data, like readmissions, which we did for a hospital in Illinois, or understand their social needs in context of a community event that takes place, or a community social related illness like opioid epidemic, where we were able to map needs and social factors against overdose rates in an area in the lower right. Next slide. We can, oh, I have slides. We can also produce this with respect to individual social factors like housing. So you can see what the base social determinants and environmental factors against a particular factor of interest is throughout an area. And by this, it does a number of things that we feel helps speed the development of a CHNA and even help complete the development of a community health needs assessment, which I do call CHNA, by the way. I don't know how many people call it that, but I've always thought of it as the initials. But it goes a long way to show graphically what the needs are and then therefore influence mechanisms for how to address those needs. We do work with a number of partners. If I could go back a slide, you'd see this community health needs assessment was produced by HSR.health, which is a partner of ours. We can collaborate and develop a full CHNA, or we can produce the data for a hospital to themselves develop the CHNA at a very streamlined price. And we can produce the data and any of the types of data sets we've shown today really within a matter of days, right? After an initial call with a hospital system to understand what data is of interest to them specifically, we can have the data produced and delivered days. And by delivered, it can be a report which has a particular map of the data sets of interest with some explanatory text, as well as the online dashboard that hospitals can use to make the data public. So make it publicly available instead of just simply a static report, but the online dashboard that Paul showed, and we'll show again in a second, can be made publicly available for hospitals and for their communities. Now I'm going to move on to the Clinician Wellness Intelligence project. This is something that's very near and dear to my heart. As mentioned, I've been on the board at Holy Cross for 9 years, and this is a project that I started thinking about and working on really right at the beginning. Really, as soon as I learned that 75% of workplace violence is targeted to healthcare workers, really targeted against healthcare workers, people whose literally their main job is to help us feel better. We have to develop solutions. If AI is good for anything, it's got to be good for the things that we can't do or don't seem to have been able to do on our own. We need an AI that cares for those who care for us. I'm sure everyone on this call knows that burnout is real. It's happening every moment of every day, and it costs a great deal of money to the healthcare system. It's also harming patient outcomes and the well-being of the clinician staff. There's no winner in the burnout problem. It's been shown to increase medical errors by a factor of 2.6 times due to burnout. And I actually take this a step further. I think the overwhelming bulk of errors that happen in healthcare, whether it's medication errors or falls or or the even hospital-acquired infections, are in great part due to the stress and strain that our clinical teams are under. I think it's entirely plausible that a very brand new nurse for a period of time may not know the operations of the new hospital where they're working, but I don't believe that knowledge deficits is contributing significantly to medical errors. Nurses know how to take care of patients. There are other factors at play, and I think that we can address them through addressing clinical workout. Here's how we see this potentially working. Where instead of a dashboard, as I mentioned, we want a conversational access to a solution where we simply can ask, and this could be a clinical nurse, a nursing leader, it could be a chief medical officer or a hospital administrator, or it could be anyone on a nursing team. Simply ask which unit is at risk today and let Anna, based on the data collected from the hospital, assess a particular unit that's at the greatest risk and potential countermeasures, which we would work with the hospital system to develop. Now, you might think that certain countermeasures like social intervention may not always work. And I think by themselves, maybe not. But as part of a program that is dedicated to improving health and well-being of the medical staff, they will work. And I say this in this regard. In the general business community, it's well established that companies that take care of their employees outperform all other companies. In fact, the list of companies on the Forbes 100 best places to work not only outperform their industry peers, but they do so by a factor of 4 times returns over a 27-year period. Essentially, it's well documented that taking care of your people does help them take care of customers and take care of the company's bottom line. I think we need to get back to that or start thinking about that in healthcare. That our focus on improving outcomes, while important, to accomplish that, maybe we take care of our clinical teams. If they're better, first of all, their turnover rates are likely to go down. Their burnout is likely to go down. Their attention to detail is likely to go up, meaning there's better quality of care, a better caring environment, better healing for patients, better outcomes, which means all of the metrics that we track, like falls, medication areas, hospital-acquired infections, average length of stay, will all improve, and the hospital will actually make more money. I think this is a mechanism to improve revenues for businesses. I'd also note that we have partners that work with us on this. Rethink Synergy, Power Up Nursing are partners of ours who want to work with us in bringing this solution to the market. And Clinician Burnout Foundation is a partner of ours who wants to work with us in funding initial pilots of the clinician wellness intelligence, so that even a pilot, which is generally a significantly lower expense than a full-blown deployment, and we will size pilots so that there is a guaranteed, or that hospitals experience an ROI before they have to pay for a full annual license. That's just to reduce risks to hospitals. And Clinician Burnout Foundation can work with us to fund that pilot effort. Now I'm going to pass it back to Paul to show us a further demonstration of the ANA application. So you might be asking why we're doing this. Technology is a wonderful, wonderful thing. Today, 35 minutes before this session, the Wi-Fi at our offices just gave out. Right? So we have limited Wi-Fi, not enough for an interactive dashboard. So Paul, who lives in a different part of the state, has a different Wi-Fi setup, is doing the technical portions of the demo. And I think that's how technology is, right? You just get it to work, whatever it takes. So this is the ANA interface. It can be customized to look like anything you want, and it allows a user to just ask a question. That I'm sure everyone is familiar with now with ChatGPT and the spread of generative AI overall. But what ANA does is that it will produce a text response. In this case, it's asking the average distance to a women's health clinic in Pennsylvania at the zip code level. So it'll produce a response of what that is. That's a number. But in addition, it'll produce a dashboard that shows the state of Pennsylvania, the women's health clinic locations at zip code levels, allowing for the person who asked the question to interrogate the data more deeply. So you don't have to know exactly what it is you're looking for initially. You can just ask a question and get started with Anna and explore the data to come up with what you want and what you need. This shows very much like the social determinants of health risk index. It shows the data down to the county, zip code, and census tract level. Publicly, we go to the county level, and it'll show the data that was requested, women's healthcare by distance and by locations. So you can look at where the locations are within the state of Pennsylvania, and we can put the map back and see which locations are far, which communities are far from care. This could be then further analyzed by population age, by demographics of any kind, or comorbidities that are of interest to assess what the risk level is. So if you have hospitals in Pennsylvania, then you can use this kinds of systems, whether in a CHNA or a certificate of need or other grant proposals, to show the need for your communities. And then we also produce data as tables and charts because there's a role for those kinds of visualizations in reports or exported. And all of this can be made publicly available if that's your interest, so that your communities can use this data to understand the scenario and the sort of the world we live in. This also meets the IRS requirement for making community health needs assessments publicly available. Okay. Thank you, Paul. Thank you. Let me go back to the slides. I promise there is not much left of the slides. Just a recap, our generative AI solution for healthcare is a solution that gets around the siloing of data. So previously, data on locations, on social factors, on hospital needs, there are maybe separate data sets. We can put them all together in a single data set. And it doesn't really take a lot of data, a lot of effort. Anna kind of does the work. Anna is the name of our solution. It's a generative AI agent that uses natural language. It's a prompt-based conversation. Now everyone sort of knows how to do that. It has access to the data, both public and private. I won't spend a lot of time on this, but this is the architectural diagram for Anna. It is not as complicated as this might make it seem. And then in summary, we are a firm that focuses on artificial intelligence solutions for healthcare risk prediction. We can certainly help with developing AI strategy or with monitoring deployment of AI solutions, our own, obviously, or others if that's of interest. We can provide expansive SDOH data really at a click of a button. So the cost structure for the SDOH data that we can give you for CHNAs is very, very low. And we can use that in a number of solutions, risk stratifying patients, all the way to addressing burnout on your clinical wards, which we're confident that they will improve the workplace environment, improve outcomes, and improve the financial performance of the hospital overall simply by removing fines for the metrics that we track. And we don't necessarily do it alone. We have a lot of partners that work with us on the community health needs assessment, that work with us on clinician wellness intelligence initiatives and other areas. We are an endorsed partner, so anything you do with us, there's both a discount of the price and a portion of the fee that goes back to ShareSource and the Healthcare Council. We do like to support the Healthcare Council. Thank you. I'm happy to take any questions. There are QR codes because everybody loves a good QR code where you can request a demo that's specific to your situation, to your hospital, and learn more about our solutions. Thank you, Carrie and Donna. Are there any specific questions that came up?
We did not have any questions in our chat today, but if you'd like to ask those now, please feel free to do so.
Hello.
Good.
My name's David Theobald. I had a question, but I should raise my hand.
Yes.
So-
go ahead.
Hello. Well, great presentation, and thank you so much. As a clinical nurse and understanding the challenges on workforce and, trying to support the health and well-being of our workforce, I 100% agree that it's going to really support patient experience, patient outcomes. Where I see AI in a lot of spaces is where they're trying to head is clinical decisions and supporting that. Where I was just at a nursing conference, and a lot of the leadership is wary or nervous on how AI may impact their roles in some of the clinical decisions in the hospital setting. So, for instance, China has a full AI hospital outside of Beijing where they're piloting AI technologies on clinical diagnosing and right now there's simulation with simulated patient models. But where do you see AI in the space with nursing, and how do you feel that you can gain the trust of not just nurses but providers and clinicians to use it as a tool, not necessarily replacing?
Right. Well,
But
Dave, it's a good question, and I think that there's two things I'd say overall, right, in this. One, artificial intelligence is the infrastructure of the future, right? Very much like cement is the infrastructure of the world we live in today. Very much like that. In that regard, the only thing we can do is learn how to use it, learn how it will work, and learn how we will interact with it. And we can only do that by engagement, right? I recognize all of the fears. They're valid that people are saying, right? And you mentioned nursing leaders and hospital leaders are worried about clinical decision making. Fair concern. We also know the worst case concern is Terminator. I would say also a fair concern because those things are realistically possible, right? We know how to program robotic droid machines. We know how to put weapons on robotic droid machines. We know how to say, go and do something, go and shoot, go and kill. So all of these risks that we see from a practical scenario through science fiction scenarios are real, but they are all worse. I'm sorry, they're not as bad as losing the AI race and being forced to adopt an AI solution that you didn't have any part of developing. So the way around it is very much like what China is doing, right? If you mentioned China has an AI hospital, why do they have a China? Why does China have an AI hospital? So they can figure out how AI can provide care. We have to do that. At some point, we have to say that we need to pilot so that we can adapt artificial intelligence solutions, such as they might be, to the workflow and the needs of our patient population. So as a company that works in this area, what we've done is what we are very willing to do is completely offload the risk from hospitals. We will say that we'll design a pilot for you. Clinical wellness intelligence is one perfect example. We'll design the pilot and we will set thresholds for the success of the pilot and charge the hospital a fee after those thresholds are met, which we then will collaboratively set those thresholds to be something that can be met in 3 to 6 months. Offload the risk from the hospital. Obviously, I'm doing that because I recognize the hospitals have real risk, real problems as a board chair of a system, right? So offload the risk in the hospital. Let the technology bear the risk. The technology is supposed to be great. It should be able to bear the risk, right? Also, as Jody mentioned, she's on the call now. We're working to raise philanthropic support for these efforts. So hopefully we can raise enough philanthropic support for a pilot at a hospital that maybe they don't even have to pay after the pilot is feed. Maybe we can find someone like the Kaiser Family Foundation or others to pay for the entire expense. That is my overall response to that. And I would say, secondly, the second response is everything you said in that question, David, is correct and from the perspective of somebody associated with the hospital, right? our patients are already using these tools in their daily lives. There was just an article in the Wall Street Journal recently about patients going straight to ChatGPT for medical care versus waiting to call their primary care physician and schedule an appointment that might be 2 or 3 months down the road. So while we may have legitimate concerns, the community we're treating does not share our concerns, not at the same level. They're already using these tools. They're already going to make their decisions based on the input they get from these tools. We have to understand them. We simply have to understand them. We have to know how to adapt these tools into the practice of healthcare delivery. I see a few people nodding their head. David Brooks, do you want to disagree or chime in at all?
I won't disagree, but you gave me the chance to chime in. I mean, I agree. I support what you said. I do think AI, and I'm a non-technician. I'm a healthcare operator, executive type, but I do think AI moves so fast that we never had the chance, almost as a society, to think through the traditional change management kind of logic of how do we make sure that people understand, the acceptance model of change. So we went right into AI is now happening. AI is an implication. AI is a threat. AI is a problem. Certainly clinicians who tend to appropriately be conservative about innovations, first do no harm, react to AI in a very skeptical way, as I don't blame them to do. And I almost wish we could go back now and think of like, what would the public relations campaign have been to create an embracing of AI, a recognition of the power of how it can assist and be a tool, which is really what it is, as opposed to it taking over and it being a threat. Because I do think many people come from that place, including myself at times.
Yeah, you're right. In fact, I'm surprised. I think actually the industry, the entire artificial intelligence industry, maybe doesn't even think enough about this, right? That the notion that AI hallucinates a significant portion of its responses, that didn't even slow down user adoption, right? So users ask AI questions to get the right answer, to get an answer. The fact that sometimes, and a lot of times, the answer is wrong, it hasn't phased the consumer. They still want to use this mechanism. So I think you rightly said it, this has been adopted without a public adoption campaign of any serious sort. So we can resist, obviously, but it's like fighting the tide. The tide will rise. You can't fight it.
If I may, hi, it's Jody. Sorry, I didn't raise my hand to chime in. I totally agree. Look, it's the new Dr. Google. Patients, well, I've always gone to Google and then scared the heck out of themselves, right? Because it would be like, oh my God, I have, my head's about to explode, when really it was like, oh, you have a migraine. You know what I mean? So I think it's just the new Dr. Google. Unfortunately, we get bizarro answers right now, and it'll get better over time. But I agree, the reliance on the AI right now, it depends on how it's applied. But I think what Ajay and what HSR.health is doing is so vital, because everyone here is really absolutely obsessed with accuracy, precision, and they're not just, nobody's out there trying to make a buck, which is why I was so excited to connect and work with them. I'm from the Clishenberg Foundation, sorry. And to be able to prepare and have such precision, and to put clinicians and executives in the best possible position, which they're not today. Everything's so reactive. And I think being able to help be proactive could be that game changer.
Yeah, absolutely. Absolutely.
I think that's a great point, Jody, and kind of to ask a question kind of off of that. Do you think that, Ajay, that at some point, there will be some AI applications that will help with some of the like staffing issues or preparing the staff for different situations they might get in, or where do you think that might go?
There are. So both of the areas that you mentioned are areas we know are challenges, right? Staffing issues, managing staffing, and staff education, continuing education, both on the clinical devices that they have to deal with, as well as sort of the other issues that they have to manage in a workforce. There are solutions to those. There are solutions to those that predated technology and artificial intelligence. Those solutions there's two kinds now. Solutions that are just simply taking the old solutions and putting a technology wrapper on them, right? Where it's a fancy way for a nurse to get mentorship, which has been happening since the dawn of the profession. But it's a fancy way for it. So it looks like it's a cool technical interface. And then there are true AI-based, machine learning-based systems that monitor nursing related outcomes and assess, you might want to say guess, depending on your perspective, what additional training is needed for that individual clinician, and then provide that training to provide modules for that training. We are not active in that space, so I can't say how effective any of them are, but solutions like that are around. We are aware of them, and we certainly can help figure out which might be right for a particular hospital and help with a deployment effort to ensure, as I said before, it has to be quick, it has to be fast, it has to have a positive ROI in the very near term. Because if it doesn't have positive ROI in the very near term, we just don't have the budget for almost anything right now. Thank you for that question, Donna, though. That's a good question.
Jay, as a quick follow-up to that along the same vein, so how do we know an AI solution will work for a particular system?
It's a great question, right? There shouldn't be any mystery around how do you know an AI is working. I'd say, how do you know Tylenol is working, right? It's a basic medicine we've been using for 100+ years. We know because we already have a set of outcomes that we tailor to. So just use the same outcomes, right? The same outcomes that you're already using, which is our patient outcomes, our metrics that we do, falls, length of stay. Are the outcomes that we're there for, are they improving? If they are not improving, then whatever new solution we put in, what value was it? What good was it, right? If it's not helping us do our main job, somehow, somewhere, it's a distraction.
Thank you.
Thank you. Thank you for the question.
Does anyone else have any other questions or comments for Ajay?
I do want to thank everyone. I put our contact information in the chat and look forward to following up with all of you.
Fabulous. And we do have a recording. So if you're interested in seeing the recording, just let us know and we will get that to you. And Ajay, thank you. Donna, anything else from you?
I think that's it. But thank you, everyone, for attending today. We greatly appreciate your attendance. Attention to.
Thanks, everybody.
And thanks for
Thank
what you're
you all.
doing,
Yeah.
Ajay.
Thank you for offering this.
Thank
But
you.
that's it.
Have a great day, everyone.